This place is not coming here. Okay, fine. Actually, my space needs to come instead of that. Some other space is coming. Yeah. Now I think so. My space will come. Yeah, fine. Yes, got it. Sorry for the delay. Right. Yeah. So today what we are going to see is the kinesiology. That is the how the rotator cuff muscle is moving individually and also along with the other muscle. So how it is doing in detail. So step by step. So we are going to see. So just let into the topic now. Hey dear, why? It's not changing. Starting trouble. Just give me a minute. It is not changing up. Up. Thank you. Right. Fine. Yeah. So first introduce my team. So we are from Good Physio Community. So our main goal is like we need to learn together. Okay. Whatever we learn, we need to put it in on the patient. Okay. So we need to practice. So once we get a proper knowledge basis as well as the experience base, then we need to lead the community. Why? We need to make cloning of ourselves. Okay. Once we become a leader, we need to make ourselves also leader. So that is the our main mantra and our main theme. I want to let you know. Yes. So introduce myself. I don't want to introduce anything. I'm Dr. Shat. I'm a sports and musculoskeletal physiotherapist. That's it. I don't want to waste your time. So happy learning, dear good physios. Yes. So what is the vision of our main community is to number one, we are already a good physiotherapist only, but we need to find it from our inside. So this is the platform that will make you find the good physio from you. Number two, so a lot of people are having good knowledge, but they are not getting enough pay. And one more thing, a lot of people, because of the broken education system, wherever we are studying or something, so whenever we are studying, we won't focus on a patient-based learning. We will focus on exam-based learning. Okay, that is not at all a true learning. With myself, I used to say. So with that, we won't get a good pay because in the interview, we don't know how to perform properly or not. So I'm going to help you to come out of that. So I'm going to make you to get a good pay. So we are also going to start a community where we are going to start like an academy as well as a clinic setup where I will help you whatever your knowledge which equal to whatever you are getting a pay. Okay, that I will guarantee you. And in Good Physio Community, whatever the content we are giving, it is like 100% transparency. We won't hide anything behind us, and we will tell us something to you and make ourselves as like higher person and yourself is a lower person. Not a story here. Actually, we are all giving the high quality content is the first main theme of ourselves. Okay, that is the core principle. Yeah, always sharing the knowledge. Okay, with full transparency, caring each other and growing together is the mantra of our success. Yeah, right. Now, what are all the instructions? So my teammates are there. So you can go through these instructions. If you have any problem with this connection or something, they will help you. Okay, so just kindly switch on your mute button, or else whenever you don't know that you are in unmute or something, if you speak, it will come and it will disturb everybody. So kindly do that, because I gave the permission to unmute yourself right now. So just use this responsibly. Number two, if you have any questions, I will give you enough time to answer for that question or to ask for the question or whatever the thing. So you have the time, I will give you that. Note down your doubts. So when the right time comes, you can ask the doubts. Okay. And if you have anything in between, you can raise your hand. So my teammate will respond to you, and stay connected till the end of the session. So don't go in between. Okay. Or else you will miss some important part of the session. And whoever stays for the long time, they will have a special gift. Okay. This is the special gift for the only for the finishers. So the special gift is they will get the free recording of this video. They will get the free recording of my one more webinar that is called Anatomy, Biomechanics, and the Pathomechanics of the Shoulder Labrum. I told everything in detail in that. So that is also you are going to get, and some coupon codes also I'm going to share for my upcoming webinars, right? Yeah. So how you can connect with me? You can connect with me using emojis, thumbs up. Okay. You can drop a message like you got a clear, a superb, if you love the content. Okay. So interact with me. And if you are not disturbing others or something, okay, if I ask a question, so that is your right time. You can unmute yourself and you can speak whatever you want in relevant with the content, right? Yeah. So what is the main objective of the today class? First, we should know what is the rotator cuff muscle individually. Okay, what are all the main rotator cuff muscle, what are the main functions. Then how they are using along with the other muscles, other rotator cuff muscle. One supraspinatus, how it is working with infraspinatus, like that individual relationship. After that, the all rotator cuff muscle, how it is working with the perishoulder muscles. That is we are going to see next. After that, what are all the pathomechanics, what are all the different types of demands and loads the muscles are getting, and what are the types of classification they are doing based on the damage severity. So those are all the things today we are going to cover. Yeah, the main syllabus for the today class is anatomy, biomechanics, and pathomechanics of the rotator cuff injury. The main reason why I called you is there are two reasons. One is like service purpose, and that is 50%. So that means I'm going to give you this free webinar. That means in this anatomy biomechanics, I won't hide anything. Everything I will let you know today itself. Okay. It is not like if you pay only, I will reveal this secret or that secret. Nothing is like that. Anatomy, biomechanics, pathomechanics, 100% you will get free. The paid thing, the rest of the 50% is the commercial purpose. So the upcoming things are how the rotator cuff muscles and perishoulder muscles are connecting with the scapulothoracic muscles. So how they are working in integratively. That is the next thing. And how to assess the rotator cuff related problems. So where I'm going to share you the videos. So that what I am doing in my clinic. So I'm going to explain in detail, like YouTube video, whatever you are seeing, right? So I will be showing those videos. So whatever I am doing, and I will be clearing you why you are doing this test. With this test, what will happen, and how you need to differential diagnose. Everything I'm going to give you in detailed structure. Followed by that, post-operative rotator cuff rehab protocol. That means I'm going to show you the exercises, not only just showing the exercises, I'm going to reveal the principles behind the exercises. Okay, so what are the principles? So step by step. First, protection phase, what you need to do. So how you need to focus on the neuromuscular activation of the rotator cuff muscle before going to strengthen the rotator cuff muscle. How you can safely incorporate into close kinematic activity in the shoulder joint. How you can safely incorporate the impact kind of loading. For example, plyometric kind of loading. For example, if you want to throw or if you want to push something and if you want to jump with your hand, okay, plyometric push-up and all, how you can integrate it properly and what are the criteria to do that. Everything in detail, day by day, I'm going to break each and every complex structures into small pieces. Okay, so those are the things I'm going to pay. Okay, that is my upcoming scenario. I will let you know the prices, everything in the end of the sessions, along with the discounts who are all staying with me until the last. Right? So this is the transparent, my motive behind today free webinar. Okay, instead of that, everything, whatever you're going to get is like completely, I'm going to tell you. Right? Yeah, I don't want to waste your time anymore. Let's begin. So all the best for yourself and myself for the interactive session. Let's begin. So before going to session, just read this muscle loudly. Okay, I'm going to read it for myself. You read it for yourself. Okay, so number of the muscle which is crossing the shoulder joint. Start from the rotator cuff muscles, supraspinatus, infraspinatus, subscapularis, teres minor. Rotator cuff muscles are over. Now, serratus anterior, latissimus dorsi, teres major, upper trapezius, middle trapezius, lower trapezius, levator scapulae, biceps brachii, triceps brachii, coracobrachialis, so rhomboides major, rhomboides minor, pectoralis major, pectoralis minor, subclavius, anterior deltoid, middle deltoid, posterior deltoid. Okay, so these are all the muscles which is crossing the shoulder. Each and every one of the muscle plays an important role in the stability as well as the mobility of the scapulohumeral joint. So that is the every shoulder complex, entire shoulder complex, not only the glenohumeral joint, it is entire shoulder complex. Got it? Yeah. Now come to the main hero of the today class, rotator cuff muscles. So there are four key muscles which is called as collectively called as rotator cuff muscle. The supraspinatus, infraspinatus, teres minor, and subscapularis. So why it is called rotator cuff? Cuff means it is like a cuffing kind of thing. You know, right? Cupping. So cupping, how it is like? It is like a cup shape material. So what it will do, if you pull from one side, it will create a negative pressure, right? Like that. These muscles, how it is structured is, these muscles are like very deep muscles in the shoulder. These muscles are located just above the layer of the shoulder capsule. What is meant by shoulder capsule? The fibrous capsule, fibrous material, connective tissue material, which surrounds the glenoid cavity and the head of the humerus. Usually, thickening of the shoulder capsule or any other capsule in the body is known as ligament. Ligament and capsule both are same in nature, same in structure, same in architecture. Everything is same. Only the names, capsule, ligament is different. Both are same. Okay. So whenever the capsule is getting thickened, that is known as ligament. Okay. So in the shoulder joint, there is a shoulder capsule, is there, right? So on the shoulder capsule, there is a active reinforcing system, active reinforcing to increase the efficiency. That is called reinforcing. Okay. That is called these muscles. Okay. So these muscles are from the superior supraspinatus, from anterior subscapularis, from posterior infraspinatus, post to inferior teres minor. These muscles are reinforcing those capsules actively as a active engines. Okay, the capsules are passive structures, as we know. It can't able to shrink. It can't able to tighten. Okay, the capsules are can able to stretch. If you stretch the capsule to beyond some certain limit, that's it. It will stretch and it will give you the limitation. Followed by that, you can't do any movement. But if you want to shrink the capsule, if you want to tighten the capsule, who is tightening the capsule? These are all the muscles which is tightening the capsule. So like a cup, I told initially, like a syringe, I told initially, these are all the muscles along with the labrum. Shoulder labrum is there, right? Glenoid labrum. So the rim of the glenoid cavity is surrounded by the labrum. Along with the glenoid labrum, these rotator cuff muscle act as a suction cup to pull the head of the humerus. So to compress the shoulder joint. So compression of the shoulder joint is known as shoulder stability. In any joint compression is known as stability. If the joint is compressed, it is stable. So what is the demand of the shoulder joint? If you take any other joint in the body, if you can take hip joint, ankle joint, or you can take a knee joint, these joints are whatever the joint articulating surfaces are there, right? For example, if you take a knee joint, the lower end of the femur, the upper end of the tibia, these are all articulating like this. Those bones are parallel with the articulating surface. Okay, those are parallel. If you press two bones together, it will get compression. Naturally, you will get the joint compression, that is the stabilization. But in shoulder, if we press two bones, that is the scapula and here the humerus. If you press from the long axis, instead of it creating the compressive force on the shoulder joint, what it will create? It will create the superior translatory force. Okay, so to be superior translating force means it is not a compressive force, it is like a displacing force. It will create the joint into some instability or some injuries. So the demand is whenever you are standing, your arm is in the dependent position. That is, this is the position called dependent position. The gravity is pulling the long axis of the humerus from superior to inferior. Thereby, inferior translating forces is always acting on the humeral head, okay, continuously. So to prevent it, these are all the rotator cuff muscle, especially the supraspinatus muscle is actively contracting, okay, actively contracting and preventing that superior translating force. So these are all the overall idea. I'm not going into deep. I'm just making yourself. So what these rotator cuff muscle usually do normally. Okay, I will come to the anatomy. Don't worry. I won't go directly biomechanics. So this is the rotator cuff muscle. So those muscles are cuff. That's why it is called cuff. Now we'll see the anatomy one by one. Right. Now, first we'll start from the posterior rotator cuff muscles. So if you take posteriorly, this is the spinous process of the scapula. On the spinous process, there is a fossa called supraspinous fossa. The medial 2/3 of the supraspinous fossa is giving supraspinous fossa of the scapula is giving attachment to the supraspinatus muscle. Likewise, inferiorly, the medial, see, if you see the articulating, not articulating surface, attachment part of the infraspinatus, if you see, this is very large. Compared to the supraspinatus, this is very large. Okay. So the total infraspinous fossa, the medial 2/3 is origination from the infraspinatus muscle.
இந்த கிருஷ்ணா அண்ணா இருக்காங்கல்ல, நீ கூட கம்பெனிக்கு போறியே, அந்த அண்ணன் போன் பண்ணுது.
This is the thing I didn't give you access to mute yourself. I will do that again. So wait. Okay, so we'll see. No, I don't want to waste your time also. Yes. Who drawn this? No, people will do it. Okay, somebody, if you can clear this line, yellow line. Yeah. Okay, fine. So where we finished infraspinatus. Dr. Pradeep. So infraspinatus. So whatever you are doing in the screen, it will be reflecting for each and every participant. So use this with pure responsibility. Yeah. Now the supraspinatus and infraspinatus origin point we see. Now we'll see the subscapularis. If you see the subscapularis origination point, it is purely a largest muscle in the rotator cuff group. It is having the largest area of the proximal attachment. So entire subscapular fossa, the lateral part, except only the medial border of the scapula is giving initiation for the serratus anterior muscle. Instead of that, each and every part of the subscapularis fossa is giving attachment to the subscapularis muscle. So this muscle is the strongest muscle among the supraspine, like among the rotator cuff. You need to remember this. Okay. Yeah. Now I have a video for you to listen. Yeah. Hi students and friends. Today we are going to see the rotator cuff muscle anatomy from origin to insertion. So now what you are seeing here is the dorsal surface of the body. So let me remove the superficial muscles. Thereby you can see the rotator cuff muscle clearly. I am removing the trapezius muscle. I am removing the deltoid muscle. I am removing the triceps brachii muscle. I am removing the latissimus dorsi muscle. I am removing the rhomboides major muscle. I am removing the levator scapulae muscle. So now what you are seeing here is the infraspinatus. Let me show you with the display names. So this is the infraspinatus and this is the supraspinatus. So we'll see the course of the muscle. If you see the supraspinatus, it starts from the medial two-third of the supraspinous fossa of the scapula and it runs laterally. Okay. After that, it goes under surface of the acromion and the clavicle. That is your acromioclavicular joint. If you see under the acromioclavicular joint, there is a blue color structure called subacromial bursa. So it passes under the bursa and it attaches over the greater tubercle of the humerus. So in the greater tubercle, if you take, there are three ridges: superior ridge, middle ridge, and inferior ridge. So in the superior ridge, supraspinatus muscle is getting inserted. On the middle ridge, that is the infraspinatus muscle is getting inserted. On the inferior ridge, the teres minor muscle is getting inserted. So you can remember this as a sit. Now we'll see the infraspinatus muscle. Infraspinatus muscle is the very largest area of attachment in the scapula. It arises from the medial two-third of the infraspinous fossa of the scapula. Okay, and it runs laterally, superiorly. Okay, from there it runs laterally and also superiorly and goes and attaches to the middle ridge and the greater tubercle of the humerus like the teres minor. So let me remove the infraspinatus now. So I'm removing the infraspinatus. Now you can see there are two muscles, one muscle below, one muscle above. The muscle which is above is called as teres minor. The muscle which is below is teres major. If you see the teres minor, it is also going laterally and superiorly and going and attaches in the inferior ridge on the greater tubercle of the humerus. Okay. So now we'll see the another muscle called subscapularis. Subscapularis is the muscle which is located between the body and the scapula. So for that we need to remove some of the muscle. So let me remove the pectoralis major muscle. Let me remove the pectoralis minor muscle. Let me zoom it out. Let me remove the coracobrachialis, biceps brachii, and serratus anterior muscle, and also the thoracic cavity, whatever. Okay. After removing all of them, you can successfully see the subscapularis just behind the body. So this is the subscapularis muscle. The subscapularis muscle having the largest area of the attachment compared to other rotator cuff muscle. It occupies the entire subscapularis fossa of the scapula. Okay, okay. The lateral two-third of the subscapularis fossa of the scapula is occupied by the origin for the subscapularis muscle. From there, it runs superiorly and laterally. Okay, the action line is very important, superiorly and laterally, and it goes anteriorly to the glenohumeral joint and it attaches to the lesser tubercle of the, that is the tubercle which will be there medially. So laterally the greater tubercle and medially the lesser tubercle. That's it. So these are all the anatomy of the rotator cuff muscle. I hope you understand. Thank you. Humerus. Who is that? Deepika Anna. You did nice job in the Annama. So can you remove this actually, this yellow line? Can anybody do that? Right control. I don't do more. Please remove that. I don't know how to remove that. Lot of drawing marks she did actually. Yeah, somebody removed. Thank you so much for that. One small thing makes time. I'll go like this. Yes. Yeah. People kindly do this, make this screen professional and responsible others also. Okay. So it's wasting others' time also. Please be serious. Or else I don't have any option to, instead of removing you. Dr. Monica, just keep eye on that who is doing that. We will remove them. Yeah. Yes. I hope you got some information from that video. Actually, the things are some missed points over there. I'm going to reveal now. You need to see always whenever you assess any muscle anatomy. So you need to assess from the anatomy view of things. Yeah. So anatomy view, like anatomy in the sense attachment view of things. From the origin to the insertion, there is no word called origin or insertion. It is like attachments. If it is near to the head or near to the center of the body, it is called proximal attachment. If it is away from the center of the body, it is called distal attachment. Okay, proximal attachment, distal attachment. That's it. A muscle can either work from proximal to distal or else from distal to proximal. Anywhere, anyhow, the muscle will work. Okay, so that is like a somebody found it origin insertion. It is like a lot of doubts are having like what is your origin, what is insertion, how we need to inject, nothing like that. Okay, proximal attachment, distal attachment. Point number one. Point number two, you see the how the muscle is starting from one point and how it is going and attaching to the another point. So one by one, if you take the supraspinatus, it is starting from the scapula, okay, and it runs directly laterally, okay, directly laterally, and it is not superiorly, not inferiorly, directly laterally, and goes and attaches to the superior part of the greater tubercle of the humerus. So thereby the action line of the supraspinatus muscle is oriented medially. Okay, oriented medially. Hence the muscle is superior to the shoulder joint. Okay, Because of the muscle is superior to the shoulder joint, it not only do the medial oriented action, it also did the superior oriented action. So it is like supromedial in the action line. That is the supraspinatus. Now the infraspinatus. From the posterior part, okay, from the posterior part, the muscle is starting from the inferior, okay, it goes superior. Now point number 1. Point number 2, from medial it goes laterally. So the action line of the muscle is infromedial. Okay, the muscle is going supralateral, the action line is infromedial. You can see this dotted line, that is the infraspinatus, infromedial. Likewise, teres minor also same, infromedial. But compared to the infraspinatus, the teres minor is more vertically oriented. So towards more inferior is compared to the infraspinatus, the teres minor is having more that. And subscapularis from the anterior, okay, it is like inferior and medially oriented, okay, in the action line. So these are all the action line of the muscle. This action line is very, very important whenever you reading the rotator cuff muscle biomechanics. Okay, so everybody got clear in this? So superior and so supromedial, infrolateral, sorry, supromedial, infromedial, infromedial, infromedial. That's it. Now, so what are the key kinematic elements? Okay, we are going to see from the glenohumeral joint is number 1, humeral head rotation. So with the corresponding flexion or abduction or external rotation or internal rotation, okay, how the humeral head is going to rotate, whether it is going to rotate anteriorly or posteriorly or medially or laterally, that is called humeral head rotation. After that, humeral head glides. So humeral head rotation means otherwise known as rolling. The glides you know, that is the translatory movement. So what are all the rolling and corresponding glides? And also the axial rotations. Axial rotation means internal rotation and external rotation. How the bone itself is rotating. So that is the thing. And along with that, what are all the clavicular and scapular motions? That is the scapulothoracic motions in relevant to the glenohumeral motions. So that is the thing we are going to see in the paid version. And the rest of the 3 things we are going to see in this free version. Okay, so we'll see one by one. Now, first come to elevation activity. Either it is a abduction or either it is a flexion. Okay, both are elevation activity only. Elevation means nothing but overhead action. Okay, overhead action. So just say take an example of abduction. Whenever you do abduction, how the humerus will move? Humerus will move laterally and superiorly. Laterally and superiorly. So as per the concave convex rule, whenever there is a fixed concave surface and moving convex surface, okay, is there. Humerus is the convex surface. It is moving surface. And if you scapula is the concave surface and the fixed surface. Whenever a convex surface is moving on the fixed concave surface, the rolling and the gliding will happen in the opposite direction. For example, if the rolling is happening anteriorly, the gliding will happen posteriorly. If the rolling is happening superiorly, the gliding will happen inferiorly. So that is the rule. Okay. Now, how we can apply this rule? Here, this is the abduction. So how the humeral head is rotating? Humeral head is rotating superiorly. Okay, it is going superiorly. So thereby the glide is happening inferiorly. Okay, fine. Rolling is happening, gliding is happening. How it is happening? Okay, because whenever we do this kind of movement in nature, the rolling will happen, right? The rolling will happen. The rolling only will happen. Sliding won't happen. If you roll the ball, a tennis ball or something on the ground, it will roll. It won't slide. Okay, it will roll and it will go out of your place to another place. So that is a constrained and unconstrained segment. That's the difference. So what is mean by constrained segment and unconstrained segment? Unconstrained segment means there is no connectivity between the ball and the floor. Okay, so there is no connection. So if you roll the ball from the one point to another point, it will roll and go away. But what is meant by constrained segment? Constrained segment means you are tying the ball. Okay, whatever the tennis ball you are using, you are tying the ball with the floor. with one place, okay? With some structure, you are tying it. Now you make it to roll. It can't able to roll. Maybe it will roll to some extent. After that, it will stop. It can't able to roll further. If it want to roll further, what it needs to do? It need to slide and it needs to come to its original position. Then it needs to start the new rolling. Again, it needs to slide to some to the original position and it needs to roll. That is called integrated movement. Okay, integrated movement. The sliding and the rolling will happen as a copulatory movement. So in biomechanics, in the nature of the body, there is no single movement like rolling or gliding will happen purely. Okay, so it will happen always a together movement. These are all the integrated movement. That is one point. Because of the constraint means the humeral head that is considered as the ball and the scapula is considered as the floor. Both are attached with the capsules, ligaments and the muscles. So because of that, it can't able to roll. If it rolls only, that means what will happen? Some ligament will get tear, okay, and it will get dislocate. That's what it's happening in the road traffic accident and all. Okay, so that is the main thing. Okay, now rolling is happening, sliding is happening. How it is going to happen with the muscle, I will let you know in successive slides. So now, as of now, you understand for what all the movement, what all the slide. For example, if you do flexion, okay, posterior, so bone will move anteriorly, okay, the rotation will happen posteriorly. This is the rolling. The humeral head will roll posteriorly, okay, the gliding will happen anteriorly. For the extension, ulta, okay, so the rolling will happen anteriorly, sliding will happen posteriorly. Likewise, if you do internal rotation and external rotation, for example, if you do a external rotation from here, it is called external rotation. From there, it is called internal rotation. Towards the body, internal, and away from the midline of the body is called external. If you do external rotation, the axial rotation, the bone is moving posteriorly. See, now it is anterior, now it is going posteriorly. It is going posteriorly, right? The gliding is happening in the anterior direction. If you do the ulta, vice versa will happen for the internal rotation. So these are all the movements are happening in the shoulder joint. Is there any other doubt? Is there any doubt for you? So you can unmute and ask me the question. So about 1 minute I will give you till now. Any doubt? Can you able to unmute yourself or else you can type in the chat, okay? Or else we can proceed to further. If you don't have any doubt, you can just give a thumbs up or else you just type no doubt or something. So that way we can proceed further. Okay, right. Thank you for whoever responded. Now, come to how it is happening. Is it happening like by itself or happening by with some force? Before that, we are going to unreveal the secret of force couple. What is mean by force couple? In our body, there is no movement called flexion. There is no movement called internal rotation, external rotation, nothing but. We have the movement of intention. Okay, intention, that's it. If I want to lift this laptop, I can lift. For that, what all the movement need to happen, without knowing myself, it will happen. Okay, it is like intention. If I want to lift this specimen, I can lift. For that, there are a lot of muscles will work as a coordinatively, lot of joints will plays the role. Everything will happen in the coordinated way. That is called purposeful activity. Whenever we want to perform any purposeful activity in the body, okay, there are some muscles, multiple muscles, not a one muscle, will work coordinatively, okay, with each other, and it will make us to do that particular muscle efficiently. So those muscles participated in particular purposeful activity, right? Those muscles are called as force couples. Okay, force couples means I will do from myself, you will do from yourself, everything as a couple, they will do. That's it. So because of that only, if you want to do any action, for example, if you want to do a abduction in the glenohumeral muscle, glenohumeral joint, So your middle deltoid muscle will work as a prime mover. Okay, that is the main muscle which is lifting the shoulder laterally. But when it lifts laterally, it can able to go anteriorly, or it can go able to posteriorly. Okay, or it can't do purely, right? Because there are three muscles are there: anterior deltoid, middle deltoid, posterior deltoid. So everything will get fired. So if everything is get fired, what will happen? This anterior deltoid force will get counteracted by the posterior deltoid. So thereby it will get neutralized. And the middle deltoid is now enabled to do the pure abduction movement. So these two muscles will act as a synergist now to like avoid the unpurposeful movement and make and enables the middle deltoid to do properly. Okay. So that is called synergist. Okay, antagonist you know already. Stabilizers are nothing but if you want to do abduction, your scapula has to be fixed. Okay, if your scapula also moving, what will happen? Instead of doing this movement, you will end up with doing this movement. So that movement has to be first stabilized by the what is this elevation? What is the other opposite muscle for the elevator? Depressor. Those muscles need to activate before going to do this action. Then only your scapula will be stabilized. Okay, that is called stabilizer. I hope you understand the prime mover, stabilizer, synergist, antagonist. Okay, so in this rotator cuff class only, I'm telling biomechanics also. These are all the extra benefits for you. Right. I hope you understand this point. So this is one more slide to make you understand one movement. Okay, that is the upward rotation of the scapula. If it wants to happen, there are three muscles from the three direction. Upper trapezius from superiorly towards medially, and lower trapezius from the superior, it goes inferiorly and medially, and serratus anterior, it goes from the superior towards inferiorly and laterally. It makes the rotation, upward rotation happens in the scapula in this direction. Okay. So this is one example for the force couple. Yeah. Now come to the active structures which will make you joint compression, which will make you gliding in the glenohumeral joint. So I told you, right, kinematics. Now come to the kinetics. What are the structures which is helpful in doing this function? Okay. Yes. Now you are not doing anything. You are just keeping your hand in your side of the body, like me. Okay. Now everyone, this is the main key point in the biomechanics of the rotator cuff muscle. So give your full attention. That way you can grab as much as possible. So now you are not doing any action. Now you want to do a abduction. So you want to do this abduction. If you see the action line of the deltoid muscle, it is purely superior oriented than the horizontal oriented. Okay, see here, this is fully superior oriented. So the vertical vector for the deltoid muscle is more compared to the horizontal vector. So this is the main muscle, right? Middle deltoid is the main muscle for the glenohumeral abduction. When the deltoid muscle fires, okay, when the deltoid muscle fires, um, as per the biomechanical analysis, the vertical oriented force of the deltoid muscle is more relatively, that means 80%, okay, compared to the horizontal joint compression force on the deltoid muscle, that is only for 20%. Because of this variation, what is happening? Because of this imbalance, what is happening? Instead of the humerus is moving in the abduction direction, it is translating towards superiorly and making the subacromial part get impinged. Everybody got this point? Okay. I'm just opening the chat box also. If you have any doubt, you can just message or something you can do. Yeah, that is the first point. Now, some counter force should be there to prevent the humeral head becoming superiorly migrated. So, for the deltoid, some of the muscles need to work antagonistically for the deltoid muscle. So, what is the muscle action of the deltoid? Superior directed humeral head force. Okay, superior glide of the humeral head is happening because of the deltoid. Now, inferior glided muscle we need. So, what are the inferior glided muscle? Anybody knows? You can type the answer in the chat box. I'll give you 10 seconds. So, what are the inferior glider? This is the very, like, in our biomechanics India Narkin, they used to tell everything. Okay, I will take. Good. Teres minor, good. See, Dr. Pradeep and Dr. Virna, you both are, what you did is actually, I told in the initial slide, the teres minor muscle is vertically oriented inferiorly compared to any other muscles in the rotator cuff muscle. They caught that point actually, and they are telling the answer exactly. Yes, congratulations for that. That is the correct answer. But teres minor muscle will be more efficient in the 90-degree position compared to the 0-degree. Okay, if you take it to 90-degree, the muscle will get sufficient elongation, so thereby it can able to pull whenever you do in the 90-degree external rotation or something. So if you abduct your arm in the 90-degree position, this is where the muscle will pull, so thereby it will avoid this. But in general, in starting, the main muscle is the supraspinatus muscle. Not only the supraspinatus muscle, one of the muscle. Okay, what is the supraspinatus muscle will do is, supraspinatus muscle first it gives the joint compression. Okay, the supraspinatus muscle from the greater tubercle, it pulls the humeral head medially. Thereby, first it creates the base. Okay, first it creates the brace. Number one, what is the base is, like it is giving the joint compression, but it can't able to do by itself. For that, it is taking the three muscle support. So infraspinatus, teres minor, subscapularis. These muscles are inferior glider, as Dr. Yamini says. Yes, ma'am. These three muscles are inferior gliders. Superior muscle won't glide inferiorly. It gives the joint compression, and inferior gliding will happen by means of the infraspinatus, teres minus, then subscapularis force couple. Why not only one muscle? Why three muscle? That is another question. If only infraspinatus and teres minor does, what will happen? Instead of you are getting the inferior glide, you will get a posterior glide. See, these muscles will pull posteriorly and humerus will go posteriorly. It is not posterior glide, it is like opposite. Anterior glide you will get. Bone will move posteriorly, glide will happen anteriorly. If subscapularis alone is does, it will go posteriorly. So it won't happen posteriorly, it won't happen anteriorly. Those two group of muscles, rotator cuff muscle, will work as a synergist to each other, and all together having a one main goal, that is the inferior glide. So thereby the inferior glide of the humeral head will happen all force coupled together if it acts as a same variation. Okay, so what you need to do before going to strengthen the deltoid muscle for the rotator cuff muscle patient, you need to strengthen these muscle. Okay, this is the key point. So these are all the inferior glider. Thereby, what will happen now? The supraspinatus muscle will initiate the action. Okay, so what it will do? First, supraspinatus will pull into joint compression along with these other muscles also. These muscles also will help in the joint compression. Now enough joint compression happened. Now supraspinatus will take the role. We used to study, right, initial 15 degree supraspinatus. Okay, it is not purely by the supraspinatus. Along with the deltoid muscle, supraspinatus will take the support of the deltoid muscle and it will initiate the abduction, because supraspinatus is not only medially oriented muscle, it is also superiorly oriented muscle. Hence, it is superiorly oriented muscle. It will give you the enough joint compression and initiation in the abduction. Because it is superior in nature, it will pull the glenoid head of the humerus towards abduction. Thereby the initiation is happening. Once the initiation is getting happening and inferior glide is happening properly, the deltoid muscle now it is ready to work. Okay, thereby you are getting the abduction. Everybody got this point? Is there any doubt? You can stop here, you can stop me, and you can ask your question. I'll give you 30 seconds for your doubt clearance. This is your platform. Okay. I don't want to dump my content. Okay. I want you to make each and every content more clear. Any doubt? Or else you got everything in track. Can I move? If you don't have any doubt, you can just message me like, yeah, everything clear, or you can go ahead or something. Thereby I will get happy. Not like repeat once. You need to ask me specific. repeating, you have the record, you can see after some time. Okay, whenever you do abduction, okay, first fire will happen from the supraspinatus and other rotator cuff muscle. There are two reasons for that: joint compression. One first reason. Second reason is inferior glide. Okay, once it's sufficiently happened, the superior translatory force of the deltoid muscle will getting inhibited. Now the abduction momentum will get activated for the deltoid muscle. Now the abduction will happen in the deltoid muscle. That's it, right? Yeah. Now the next slide. You can see the representation in the picture. Deltoid muscle is superiorly doing, and inferiorly the subscapularis infraspinatus teres minor is like gliding inferiorly. Supraspinatus is initiating, and now deltoid is doing abduction properly. That is the image. The same. The superiorly translate force for the deltoid is more. See the pull of the supraspinatus supromedially oriented. So now the recap. So we completed the biomechanics of the rotator cuff muscle. Okay, now the recap. So if you want to do proper glenohumeral joint motion, what all the things need to happen is kinematically rolling and gliding of the joint should be happen. Okay, so rolling will one direction, gliding will be opposite direction. And so what all the for the abduction is needed is for the flexion, posterior rotation and inferior glide. For the abduction, medial rotation and inferior glide. For the extension, anterior rotation of the humeral head and the inferior glide. For the external rotation, it will rotate externally. That means it goes posteriorly, thereby the anterior glide will happen. For internal rotation, vice versa. It goes in anteriorly and posterior glide will happen. So these are all the things. Okay. Now come to the pathomechanics of the rotator cuff muscle. In the biomechanics, instead of whatever I told, is there anything you want to ask me? Is there any other thing you want to ask me? Rotator cuff muscle, regarding rotator cuff muscle. If you have any like a specific doubt or anything you want me to clear, I'm just opening the chat box. What is the role of teres major? Yeah, teres major usually comes, it won't comes under the joint compression, but it also helps for the rotator cuff muscle, but it won't merge with the joint capsule. So hence it is not merging. It is a secondary stabilizer. It is a medial rotator muscle along with the subscapularis muscle. The teres major muscle also a medial rotator. It helps with the other rotator cuff muscle, especially the medial rotator subscapularis muscle, and it gives us a secondary stabilization, not a primary one. Okay. Now, whenever you do any movement, the joint has to be fully stable. That means the glenoid, the humeral head has to be centered in the glenoid cavity. Centering of the humeral head, which is purely done by the rotator cuff muscle. Whatever movement you do this movement, lifting movement, side lifting movement, the centration of the humeral head is done by the rotator cuff muscle altogether. Okay, so the muscle will be keep on firing without taking any rest. You can use a pectoralis major muscle to do the chest press workout. You can do the deltoid muscle and upper trapezius muscle to do the chest shoulder press workout. You can do the latissimus dorsi muscle to do one arm rowing. Whatever exercise if you do also, whatever the muscles are can change the perishoulder muscles, but the rotator cuff muscles it won't get changed. Okay. Maybe the proportion might get changed, but each and every rotator cuff muscle will be playing an important role in delivering the joint compression, gliding sufficiently to act. Okay, so the gliding also will be done by the rotator cuff muscle only. Along with that, the joint compression also done by the rotator cuff muscle only. Okay, these are all the two key elements will be done by the rotator cuff muscle. If the rotator cuff muscle is having any problem or something, what will happen? This gliding won't happen, so reverse gliding will happen. Because of the reverse gliding, some structures will get impinged. Because of the reverse gliding, some passive structures will get tear. So what are the impingement? Subacromial impingement or posterior shoulder impingement like internal impingement. Okay, the labrum will get tear. And structures, labral tear will happen or shoulder dislocation will happen. These are all the things will happen. if the rotator cuff muscle is not doing the work properly. Why is the infraspinatus the weakest rotator cuff muscle, sir? What is the biomechanic behind it? Who told? It is not weakest rotator cuff muscle actually. So as per the size of the muscle, if you see the teres minor is the weakest muscle in the rotator cuff. Okay. So infraspinatus is before that. Actually, the muscles is having the large cross-sectional area to sufficiently rotate the humeral head externally. It is not weakest. So weakest or strongest, how you can decide is because by depends on the muscle mass. Okay, if the muscle is large enough, it can be a strongest muscle. Usually, what demand you will have an internal rotation demand more. That's why God created this subscapularis muscle more strong to prevent the anterior dislocation. Usually, the anterior dislocation used to have common. Whenever we do external rotation more than normal range, the humeral head will anterior glide and it will come out of the socket. To prevent it, the subscapularis muscle is doing the excellent job by preventing the excessive anterior glide. Yeah. So Dr. Shaikh Navid, if you have any like further doubt or something, you can drop a message in like regarding this. If you are not getting any clarity, you can drop a message in the WhatsApp group. I will read and let you know if is there anything like that. Okay. Can we enter into the pathomechanics of the rotator cuff muscle? Till now, everybody got clear? Yeah. So these are all my way of understanding. That's why I'm giving my name. One second. Yes. So what are all the biomechanical types of overload? Okay, there are overload in the glenohumeral joint. That's why we are getting rotator cuff muscle or any other problem in the shoulder. So what are the type of overload the rotator cuff muscle is getting? So I split it into 5 types of overload. Okay, number 1, high angular velocity movements. That means high speed movement combined with end range joint excursions. That means overstretch. Okay, this is the type 1. Type 2, sustained isometric contraction in fixed joint position, holding the joint in one position for a long time. Repetitive concentric and eccentric loading cycles. This means same movement repeatedly they are doing, okay, more than the normal limit. High intensity resistance resulting in increased torque demand across the glenohumeral joint. That means whatever the load they are doing, right? They are doing against the load. They are increasing it more than their limit. Maybe it is like a weight they are lifting, whatever they are doing. That is the high intensity resistance. Frequent close kinematic activities involving anti-gravity stabilization and dynamic body weight. Gymnastic and all they used to do, yoga and all they used to do, CrossFit and all they used to do, calisthenics they used to do. What they used to do, they will used to stand on the hand, okay, stand on the forearm and jump with the hand. Whatever they are doing repeatedly, that will make more demand in the closed kinetic chain activity, the kinetic chain demand. Okay, so that will put more load on the rotator cuff muscle and making it get involved in the injury. So these are all the 5 types of injuries which will come to the anybody whoever going ahead with this. Okay. Now we'll see one by one in detail. First, we'll start with the high angular velocity movements combined with end range joint excursion. What is meant by that? Activities involving high angular velocity. So whatever you are doing, the badminton or javelin throw or something, what it needs a end range joint motion. Okay, that means more than the normal range. It needs actually, and it needs to very high velocity movement. These are all the both things it needs. So what will happen actually, if we do that, the muscle firing rate should be very superimposed. Okay, it should be very much compared to the normal people, it should be very, very fast. The reaction time, if it is less than 0.1 millisecond also, if the rotator cuff muscle is not getting activated, and directly it will end up into the any impingement or else any passive structure tear. Okay, so this is the main thing. So this is the one kind. So examples are the throwing sports, racket sports, swimming, martial arts. So especially what will come? The throwing sports will come, racket sports will come, swimming also will come because of this fast in nature. But the main things are throwing sports and the racket sports, not any other thing. And stretching, gymnastic, why I told end range they used to do, right? That's why it is called gymnastic. So these are all the main things, the three things: throwing sports, racket sports, and gymnastics. So the impact, the fact is, while you are throwing, the shoulder used to move. Usually, what is our normal external rotation range is like 70 to 90, right? But for the thrower, how much it will rotate? Like approximately, it is like 170 to 180 degree. It will rotate like this. It will go like this completely, okay, and it will come. And how much fast it does? 7,000 degrees per second speed it does. That means you think of the demand of the sports play, right? Yeah. Now, I will come to the picture after some time, after discussing this. Now, what is the second thing? Sustained isometric contraction in the fixed joint position. So, what are all the things? So, whenever you are going to those kind of demand, the muscle need to produce the force isometrically. Isometrically, muscle needs to, without taking rest, 1 second rest also, the muscle needs to work. If you're giving in the optimal time, no problem. If you're not giving rest within the optimal time, then the muscle will get fatigue. Usually, rotator cuff muscles are fatigue resistant muscle only. All stabilizer muscles are fatigue resistant muscle. Those are all having high proportion of type 1 muscle fibers. But still you are giving demand more than that, what will happen? The rotator cuff muscle will get fatigue. If the muscle is getting fatigue, there is a neuromuscular fatigue will happen. Okay, the muscle will reduce in the strength. Whenever the muscle is getting reduced in the strength, again, if you are giving any high demand, what will happen? It can't able to do the stabilization activity properly. Then followed by that, these problems will happen. Yoga master, not yoga student. Yoga master used to do for 3 batch, 4 batch continuously, they used to get. Continuously yoga pose, they used to get. Construction, occupational related, painting and all overhead installation like ceiling work, okay, tube light work or something, big work and all, they used to have these. Sustained arm abduction and flexion. So whatever the orthopedic surgeons or dental surgeons used to have this position, right? They may used to get it. They won't get within 1 day or 2 days. It will get compound over the period of time after a 6 month or with a depends on the current strength and all, their current maintenance and all. It will happen depends on the demand of the person to person. It will vary. So these are all the things. Realme 6, raise your hand. Yeah, give me your question, man. You can ask your question. Who raised your hand? Yes. Who is the Realme 6? Is there any doubt? If you have, you can ask, or else you can lower your hand. We will ignore your hand now. Okay. There is no response from your side. No chat also. Right. So everybody got this point? Sustained isometric contraction. Next. This is the sustained isometric contractions. So we used to hold like this, okay? And surgeons and installations, painting, sustained we need to use. Now, repetitive concentric and eccentric loading cycle. What is mean by repetitive? That same movement used to repeat for a long time. Okay, repetitive movement patterns place considerable cumulative stress on the shoulder complex. So we need to do the internal external rotation, internal external rotation. Who will do? Swimmers will do. Swimmer will used to do in butterfly strike and all. They used to do like this, whatever strike, freestyle or else a breaststroke or else a backstroke or whatever. Repeatedly they used to do. Okay, by doing repeated in nature, those muscles will get fatigued, and because of this is getting fatigued, then 1% if the strength is getting reduced in the rotator cuff muscle also, it will lead to the impingement or some other problem. They used to get those kind of problems. Okay, so see the thing, continuous load, dynamic loading can result into neuromuscular fatigue, which result into first tendinitis, after that tendinosis, after that tendinopathy. So, and muscle activation imbalance, increasing the risk of over injuries. So common in swimmers, okay, common in swimmers, and common in middle age women's they used to do repeated vessel washing, scrubbing, or gardening works and all. Some people used to do, right? So repeatedly they are doing over the period of time, it will come. So that's why I mentioned in the swimming. Now the next thing is high intensity resistance in increased torque demand. Torque means force production. Muscle needs to produce the force. That is called as torque. How much it is rotating. The muscle is rotating the joint. That is called torque demand. That is against the high intensity resistance. So high intensity physical activities. So especially you can say weight lifters, Olympic lifters and all, the high resistance will be there. That is the one thing. And rapid acceleration and deceleration. What is mean by that? Whenever you do throwing and all, okay, you are doing the throwing, you are generated the high resistance. With your body, you generated the high resistance with to the ball. So ball will go. Along with that, hand also will go, shoulder also will go. You need to prevent the shoulder from going forward. You need to decelerate the hand. Okay, at the stage of deceleration and follow through. Okay, the recovery phase of the throwing, you need to make it control yourself. If the posterior rotator cuff muscle, especially those are all the muscles, will do that work along with the posterior deltoid muscle. If that muscle is not activating within the time, what will happen? The shoulder will go like awkwardly. So if it goes awkwardly, more posterior impingement will happen. Because of the posterior impingement, the slab will, not the slab, the reverse band cut. Okay, that is the main thing. It may get tear. That is the posterior part of the labrum. It will get tear. So these are all the things won't happen within 1 day or 2 days. Okay, if you are not conditioned yourself properly, if you don't fit yourself, okay, before doing this kind of demand, then only you will get. So because of they are doing high speed, that is the one thing. They are doing extreme range of motion, that is the another thing. And they are doing continuously, repeatedly they are doing. That is another thing. So all together, what will happen? Make the muscles will go for fatigue and make the muscle vulnerable to go for the give up stage, and it will get tear or something. Okay, these are all the things. Now examples for that: Olympic lift, power lifting and all. Explosive movement like throwing action, javelin throw, baseball throw and all. These are all the things. Contact sports like rugby, you need to push somebody continuously. So with that thing also, if the opponent is so strong, you will get like a traumatic. Okay. Now the last one, frequent closed kinematic chain activities involving anti-gravity stabilization. That means whatever you are doing, weight bearing. Okay, weight bearing in the sense the yoga poses, gymnastic poses, CrossFit and all I told you, right? So with the weight bearing, what will happen? The muscle will work in the reverse way. Reverse way means what? The humerus will be fixed, but the scapula will move. The humerus is fixed, the scapula will move. Okay, you will be on the push-up position and moving your body. Okay, you will be on the plank position and you will be moving on the body. The transition from the yoga poses, from the push-up pose to, they used to go handstands and slowly they come to the push-up pose. They used to do these kind of things, right? Then the muscles will need to work like compared to normal people. That is like a sports and all high velocity demand, and this is high stability, high resistance in demand. The muscles need to work properly with coordination with each other muscle. If it is not work like that, then what will happen? The translation will happen little bit awkwardly more than the limit range. Either the muscle will tear or else the other joint structure will go with injuries. So this is the main thing. So here the neuromuscular control is important. Dynamic stability is important. Okay, for the coordinated strength from the shoulder complex. Neuromuscular control means within the muscle, it needs to control. Along with the rotator cuff muscle, the scapulothoracic muscle also need to coordinate with the glenohumeral muscles. Is there any doubt till now? This is your time. Is there any doubt? Is there any doubt in pathomechanics? Now I will give you the conclusion in the pathomechanics. So what is the conclusion? First, whatever the 5 type of demand if you do, it will make the muscle fatigue. Okay, depends on the person to person, it will vary and depends on the volume of the training. Okay, how frequently you are training, you are not giving proper rest in between, periodization, poor periodization you are doing, you are stressing the muscle too much, you are deconditioning your muscle too much, and you are not making the muscle with the proper mobility training and all. Because of the stiffness also, the muscle can't able to move with a particular range and all. Whatever the reason, fatigue will happen in the rotator cuff muscle because of the overuse. Number one, because of that poor stabilization of the humeral head on the glenoid cavity, poor centralization effect on the humeral head. Because of that, increased translation will happen. Whatever the anterior translation, posterior, superior translation, it will get increased. Because of that, impingement between the humeral head and the acromion might happen. Or else, whenever you do this particular action, the rotator cuff muscle needs to resist it, right? Okay, whenever the load is coming against the rotator cuff muscle, it should have a proper strength to accept the demand. If it is not having the proper strength to accept the demand, it can't able to resist the demand. What will happen? It will go for give up stage. The muscle will get tear, micro tear. Depends on the load. If the load is so heavy, it will go for a macro tear also. Traumatic conditions, it will go for a macro tear. Micro tear means repetitively they will be having a small pain initially, they will be neglecting, repeatedly they will doing, then it will over the period of time will come. So micro tear because of the excessive demand. So if you are doing repeatedly, poor healing will happen. And because of that repeated loads over the period of time, the healing capacity of the particular structure will get disturbed. Okay. So that means the blood circulation to the muscle will get disturbed. The healing capacity of the collagen fibers inside the muscle, inside the tendon will get disturbed, not the inside the muscle, inside the tendon. Okay. Tendon will get disturbed. So poor healing capacities. Okay, because of the poor healing capacity, the degeneration will happen. That is called tendinosis. From tendinitis, tendinosis. Okay, after that, it is like a tendinopathy. Tendinopathy means the tendon itself will be like weak in nature. If you load the tendon, it will give you the pain. Okay, the tendon will be in the stage of it can't able to repair, irreparable stage. Now you need to do the load management properly to get the tendon into bring back to normal stage. It is like so difficult. It will take more than 9 months. If you are training any sports person or something with the tendinopathy, there are some protocols you need to use very, very, very slowly. You need to go. That is the last stage. Yeah, this is the pathomechanics of the rotator cuff muscle. Till now, pathomechanics got over. Now come to the rotator cuff tear classification and concept. This is very like small topic only. Within 2 to 3 minutes, it will get over. Now there are out of 50 people, only 34 members. So you 34 members are like more serious on your career. Actually, 105 members are registered. With that, 50% are showed up. With that, only 34 members are still now because the time is nearly 9:49 Sunday night. Okay, so good physio needs only the people who are very serious in their successful. Okay, this is why we are. I'm doing this is I'm successful. I want to successful. That's why I'm doing. But at the same time, why you are listening? You want to be a successful person. You want to show up like separately from other persons. For that, we need to learn from something. So there are some books are there. There are some online sources and also some webinars. So always I used to learn from the webinars or some YouTube videos from some great lecturers. Why? Because those lecturers or those mentors, they spend a lot of time to create a like it is like a easy route to learn very easily, quickly. Okay. So always that's why I believe in learning webinar and learning in the live sessions. Okay, going and learning from the mentors are more powerful than learning in the book or learning from the little bit of articles or any other online stuffs. Okay. Yeah. Now you people tell me if you have any doubt in this, you can ask me. This is your time. Okay. You can ask me a doubt. I will clarify you. If you don't have any doubt, so you 34 people, whoever can, you can just type the message that we are on track and we are clear with the content. I'll be happy to see that whatever you are giving. Thank you, Dr. Sopika, Dr. Revati, Dr. Shaik Navid. Dr. Sindhu, Dr. Pavan, Dr. Saipriya, Dr. Aishwarya. We are on track, sir. Please go ahead. Thank you, sir. Thank you so much. Right. Thank you so much for your interaction. It boosts me. It boosts my energy a little bit. Yeah. Now rotator cuff tear. Some people used to tell like this pasta tear. Anybody heard pasta tear in the supraspinatus? P-A-S-T-A, pasta. Not eating pasta. Pasta tear. Somebody used to tell buccal surface tear. Somebody used to tell it is like a partial thickness, full thickness, and massive tear. Anybody heard in MRI while seeing MRI? I'll let you know now. So first come one by one. If you take a shoulder joint, okay, depends on the location they used to name it as. Acromioclavicular joint will be there. Okay, able to see, I think so. Yeah, this is anterior. Acromioclavicular joint. Okay, beneath that there is a supraspinatus muscle. Between the supraspinatus muscle and the acromioclavicular joint, there is a one structure, quaternary structure called subacromial bursa. So supraspinatus muscle superior surface is, if it is getting involved in the tear, that is called bursal surface tear, superior surface tear. If the inferior surface is getting tear, that is called pasta tear, partial articular surface tear of supraspinatus muscle. Okay, that is called pasta tear, partial articulating supraspinatus tendon. Okay, our tear or something they used to tell here. Okay, that is the pasta tear. And what is mean by partial thickness? What is mean by full thickness? I will let you know. This is the tendon. Okay, this is the tendon, and I am making the tendon very thick. Okay, this is very thickened tendon. Superiorly, if it got teared, only superiorly it got worn out. It won't tear like this. It won't get cut. It will worn out from superiorly. That is called bursal. That is a partial thickness tear. That is a one of the partial thickness tear. And if the thickness, full thickness is getting tear, full thickness is getting cut, that is called full thickness tear. But still, I will let you know one more mechanism also now only. Right. When what you are thinking is the tear means it is like a cut in the thread. It is not like cut in the thread, it is a hole in the cloth. That what is mean by hole in the cloth instead of cutting the thread means if you take the supraspinatus tendon, here it is completely, it is whole, it is like completely torn. That is a full thickness. Here it is in the center part of the tendon is full thickness, but you might having a good tendon connection between the muscle and the tendon in laterally or medially, so like anteriorly or posteriorly. Maybe in the middle portion, full thickness tear, but still you are having some connection between the proximal and the distal. Okay, it is not like 100%, it may be a 90% or it may be 80% or something. In the supraspinatus muscle, it will be happening like that only because of the degeneration, like little by little, it will happen. And what it is mean by a complete tear, that is called massive tear. Massive rotator cuff tear is known as complete. Everything will get tear, and after the tear, what will happen? The muscle will go retract, it will go like this, and the tendon will come like this. This is called retraction. Retraction will be there. There is a distance between the muscle and the tendon. You can't able to joint. If you have a partial thickness tear, if you have a full thickness tear, you can able to join it by means of rows and all. Okay, stitches used to tell in the common term. Okay, you can put the stitches. But if it's a massive tear, you can't do. What you can do there, you can do reconstruction. So used to call it as superior capsular reconstruction procedure. I will let you know in the upcoming post-operative webinars. Okay. I hope you understand this point. Is there any doubt? Yeah, this is that. Rotator cuff tears are not like rope snapping. They resemble a hole in the cloth. So progressive fiber degeneration. Most common in degenerative tears, supraspinatus articular side. Usually it comes like that. Okay. So because of the chronic overload, the muscle will get poor healing capacity. Then slowly everything will get tear. After that, it will be a massive. Traumatic also you can see massive tears. Traumatic tears. Okay. With the accident or somebody, they will fall from the step on the shoulder. They will get the tear, right? They will also have a massive tear. Now see the classification now. massive tear. The tear size is more than 5 centimeter. Okay, the tear size is more than 5 centimeters is massive tear, or else more than two tendons are involving. For example, the supraspinatus muscle also getting tear, okay, full thickness or something, along with the infraspinatus muscle also having tendinosis, or else it is also having some tear. So if it is more than that, if it is two or more than two tendons are involvement, it is a massive. So poor healing and poor recovery. So often shows tendon retraction, and because of the tendon retraction, the muscle won't do any participate in the force production, so it will get atrophy, and the muscle will be replaced by the fat over the period of time. That is called fatty infiltration. So that is the massive tear. You need to do surgery, nothing you can't do. If they are old age, they need to live with that with some kind of restriction. That's it. Now, the retraction, how it is classified is stage 1, stage 2, stage 3. The muscles are fully cut, but the proximal and distal attachments are like on the lateral to the humulate. It is here only. That means it is stage 1. They used to see in the MRI. If it is coming and it is staying at the humulate, that is stage 2. If it is beyond that, it came to the medial to the glenoid. That is means medial to the scapula glenoid. That means it is stage 3. For stage 3, we can't do anything in the repair. We need to do for replacement only. And here, come here. Partial thickness, incomplete tears, may be a bursal tear, superior surface, articular, inferior surface, or intrasubstance. Full thickness, complete detachment through the tendon depth. So full thickness are not really a massive. It may be like a some connection might be there. Okay, in rotator cuff alone, you need to understand like this. Full thickness also, as per the evidence, full thickness tear, 70% of people we can manage conservatively. Okay, either in the pain or strength also we can bring back because of the cloth in the hole analog. If it is a cut in the rope, it is like a ACL, we can't do anything. Okay, so that is the difference between that and this. Now partial. So if it is a partial, patient will be having a pain because some connections in the muscle will give you the pain, and weakness also will be there, but more than the weakness, pain will be more. If it is a full thickness, okay, if it is a full thickness, pain also will be there, weakness also will be there. Because in full thickness also some connections will be there, right? So with that also, pain also will be there, weakness also will be there. But with the partial, weakness will be less, but the full means weakness also will be more. That is the differentiation between the partial and full. If it is the massive, pain won't be there. Patient will literally do the hiking sign. And drop arm test also will be positive. I will let you know in the assessment, okay, in detail. Now management is depends on the things. I will give you the criteria also in future classes. So these are all the tier classification. I hope everybody got this point. Now, so this is the time to distribute the gift for the residual 33 peoples. Okay, with that also one people went within this 2 minutes. Unlocking the gift. Yeah, link for the labrum description. I will share you the link now. You just open now. I will give you the access. The thing is, you need to do now only. If you do after some time, you won't get the access. Okay, because anybody can do that, right? That's why I will give you the link in the description now. Meanwhile, if you have any doubt, you can ask me. This is your time. Whatever you want to ask, you can ask me. Or else you can tell your feedback also. I'll be happy. Is there any feedback? No feedback also. Just a minute, I'm sharing this. Why nobody are speaking? My old students, anybody? There are some messages are coming. Let me see. Yeah, got the link. Just open the link now. Okay, I'm just giving the access now. We'll do within the 2 minutes. You just click the link and it will request for the access. Yes. If you don't have, if you're not getting the access also, no problem. I will be having this message with me. Just give me only one time. Okay, I will just share. I think some of you are getting now only. Dr. Pradyut, Dr. Shruti Jain, Dr. Sopika, Dr. Mohit, Dr. Aishwarya, Dr. Subhash I already gave you, Dr. Priya, already, yeah. Yes, yeah, did. Now I want to just introduce a little bit more gift for you. Wait, it's not coming. Can you able to see the screen? Actually, I don't know what to say. With the right time, my Zoom company is doing nice job for me. I can't able to access the Zoom now. I can't able to. Came. Thank you. You heard, I think so. First fellow. Okay. So yeah, whoever not got the access, I have the notification. Once I finish this class, I will give you. By tonight, you will get. Okay. And we are having in the group also, right? You can share me the separate message. You know my name, number actually. So I will give you that. No problem. You will get the access definitely. Now I want to share you this video. Can you able to see? Hey dear good physios, welcome to the Good Physio Community. I hope everyone are doing great. Now, I want to ask you that how many of you know 40 to 60 percentage of subacromial impingement, rotator cuff tears, labral tears, lateral epicondylitis, and even TFCC injuries also is coming because of only one reason, and that reason is the scapular dyskinesia. By correcting the movement pattern of the scapula, you can fix these problems more efficiently. However, knowing the type of scapular dyskinesia, pathomechanics behind the scapular dyskinesia, and how to assess it, and how to program an evidence-based rehab protocol for these patients are key elements. And myself, Dr. Sharath, I am a sports physiotherapist. I treated more than 100 cases in scapular dyskinesia, and I am going to help you from basic to top everything in detail in upcoming 3 days webinar. Not only that, I am going to provide a high quality recording video and also the certificate for participation. Then why you are waiting? Just register now, update yourself and get master in this scapular dyskinesia. See you there on the webinar. Until then, take care. Okay. So this is my upcoming webinar. So that is in regarding with this scapular dyskinesia. That is different from this rotator cuff upcoming classes. Okay. So the thing is, yeah. So actually, for the upcoming video webinar, if you are typing this, I am a good physio 20, so you will get some kind of discount in that. Okay, you'll get instant 20% discount. You can use for your friends or you can use for anybody. You can get that. So if you do a spots registration for the Rotator Cuff webinar by today, you'll get a 30% discount. Okay. At the same time, if you're doing for a scapular dyskinesia along with the Rotator Cuff webinar, you'll get a 50% offer. So this is like a commercial purpose, I'm openly saying. But the thing is, where you are investing on yourself or else other like in the liability things. So that is the question actually. So if you are interested, I will just share you the link and as well as the QR. So you can just finish your payment and you can just register through the link and you will get the further notification for the paid webinars. Okay. So just for the 3 to 4 minute job. After that, we can wind up, right? So the people who don't want this, the people who just want the only the free things, you can leave now. So we want only the people who are very serious in their successful. Okay. So I'm not forcing anybody. This is up to you. That's it. So I'm just sharing the picture now. You can just scan through your phone itself from here, and I'm just sharing the link also here. Yeah. So this is the picture for the payment. So you can just take a QR scanning from whatever UPI app you are using. You can do that. I'm just keeping here for you. And meanwhile, I'm sharing the. Dr. Monica, you can share the link directly to the chat box. You can directly share the link to the chat box, thereby everybody get the access. Okay. You just type like RC plus RD if you are paying for the both webinars. Just 6 more minutes. Okay, 5 more minutes. I am just giving you. Meanwhile, anybody have any doubt, you can ask me, whatever. I'm here to clarify you. If you have any problem with the registration or something also, you can ask, no problem.